All right. Close the door. Turn off the notifications. Put your phone on silent. Adjust your chair. We are doing something very different today.
Yeah.
Usually on the deep dive, we take a topic and explore it with a bit of, casual curiosity, looking for those fun aha moments. But today
Today is different.
Today is about survival.
It is. We are shifting gears from trivia to high-stakes performance.
Exactly. I'm fully in role-play mode today. I'm the candidate. I'm probably over-caffeinated, definitely sweating a little bit. And I am staring down the barrel of the Gujarat University MD Anesthesiology exams. And you.
I am the senior faculty.
You're the examiner who has failed students for hesitating on the basics.
Yeah.
You are the one holding the pen that decides my fate.
I am the examiner who knows that if you do not know your physiology, you are dangerous in the operating theater. We are treating this deep dive as a dedicated Viva preparation session. We are targeting 3 massive, high-yield topics that appear in almost every exam cycle: the autonomic nervous system, pupillary reflexes, and postoperative cognitive dysfunction.
The dreaded triad, as some of the postgrads call it. And just so everyone listening knows the ground rules, we are pulling this directly from the canon. We have Miller, Morgan and Mikhail, and Guyton for the hard physiology.
Those classics.
We got Stolting for the pharmacology. And we're also using those specific exam-oriented notes like Kaushik, Jothanath, and DMB questions to make sure we hit the key words the examiners are listening for.
Precision is the goal here. In a Viva, you cannot just wave your hands and say, the heart rate goes up.
Right.
That is an MBBS answer. In an MD exam, I need the pathway, the receptor, the neurotransmitter, and the clinical implication. If you waffle, you lose the medal. So put your candidate hat on. Are you ready?
Hat is on. Pen is ready. I want to start with the beast. Part A, the autonomic nervous system, or ANS.
Part A it is. The ANS is the absolute bread and butter of our specialty. So, candidate, let's start with the opening gambit. You walk into the station, I look at you over my glasses, and I ask, what is the autonomic nervous system? Do not give me a generic answer about automatic stuff. Define it.
Okay. Leaning heavily on Guyton here. The autonomic nervous system it's the specific portion of the nervous system responsible for controlling our visceral functions. It operates largely below the level of consciousness. We are talking about the regulation of arterial pressure, gastrointestinal motility, secretion, urinary bladder emptying, sweating, body temperature, all of it.
Good. And what is let's call it the teleological goal. What is the system trying to achieve every second of every day?
Homeostasis.
Exactly.
It is the great coordinator. It keeps all these separate organ systems, the heart, the gut, the vessels, working in harmony to maintain a stable internal balance.
And if that balance fails?
If that balance fails, like in severe shock or sepsis or massive trauma, the organism dies. It's that simple.
Correct. Now, why do I, as an anesthesiologist, care so much? Why is this 20% of your exam paper?
Because anesthesia is essentially the controlled manipulation of the ANS.
Go on.
Every single time we administer a spinal block, we are inducing a chemical sympathectomy. Every time we give neostigmine to reverse muscle relaxants, we are boosting parasympathetic activity. We are constantly either fighting the ANS like treating bradycardia with atropine or, using it to our advantage. If we don't understand the ANS, we are just flying blind with the hemodynamics.
Precisely. Now, structure matters. In a theory exam, this is often a 20-mark long answer question. You need to classify the system immediately. So how do you divide the ANS?
Okay, so traditionally, the most common way is to divide it into the sympathetic nervous system and the parasympathetic nervous system.
Stop. Right there.
Oh.
You've already missed a point. A big one, and it's a favorite for physiologists. A point that Guyton emphasizes heavily.
Ah, right. The enteric nervous system.
Never forget the enteric nervous system. Why is it significant enough to be a third division? Is it just a few nerves in the stomach?
No, it's massive. It's often called the second brain.
Right.
It's located entirely within the gut wall, from the esophagus down to the anus.
It is not just about location. It is about scale. Give me a number.
It contains approximately 100 million neurons.
And what does that compare to?
That is roughly the same number of neurons found in the entire spinal cord.
Right. That is a statistic that wakes an examiner up. It shows, the sheer scope of what we're talking about.
100 million neurons just for digestion. That's actually staggering. So does it run the show entirely on its own then?
It controls gastrointestinal movements and secretions semi-autonomously. It has its own reflex arcs, its own pacemakers. However, and this is the key nuance, It is heavily modulated by both sympathetic and parasympathetic inputs. So for your exam table, you have 3 columns: sympathetic, parasympathetic, and enteric. Now, let's drill down into the functional anatomy of the big two. If you are drawing a comparison table, which you absolutely should be doing in the exam, what is the first row?
Origin, the outflow.
Walk me through it. Sympathetic first.
The sympathetic system is thoracolumbar. The preganglionic fibers exit the spinal cord from segments T1 down to L2 or maybe L3.
And that's a parasympathetic.
The parasympathetic system is craniosacral. That involves cranial nerves, 3rd oculomotor, 7th facial, pharyngeal, and of course the big one, X vagus, plus the sacral segments S2 to S4.
Good. Now, the second row in your table, ganglia positioning. This is critical because it dictates how the systems fire. Explain the difference in architecture.
In the sympathetic system, the ganglia are generally located very close to the spinal cord. We're talking about the perivertebral sympathetic chain or the prevertebral ganglia.
And what is the functional consequence of that architecture? Why put the ganglia there?
It allows for mass discharge.
Explain that term.
Because the ganglia are all interconnected in a chain right next to the cord, one signal can trigger a widespread, simultaneous response. It's the fire alarm system.
Yep.
You know, when a tiger chases you, you don't want just your left eye to dilate. You want the heart, the lungs, and the muscles all activating together instantly.
Exactly. The fight or flight response needs to be global and immediate. Now contrast that with the parasympathetic side. Where are its ganglia?
Parasympathetic ganglia are located very close to, or actually embedded inside, the wall of the target organ. They're called terminal ganglia.
And the consequence of that?
This architecture prevents mass discharge. It allows for discrete, localized control. I can constrict my pupil to read a book without simultaneously slowing my heart rate, salivating, or emptying my bladder. It's highly specific.
Excellent distinction. Mass discharge versus discrete control. That's a perfect subheading. That structure leads us directly to fiber length, doesn't it?
It does. Since sympathetic ganglia are near the cord, they have short preganglionic fibers and then long postganglionic fibers that have to travel all the way to the organ.
And the reverse for parasympathetic.
Exactly. The parasympathetic system has long preganglionic fibers that go all the way to the organ, and then very, very short postganglionic fibers that just synapse right there in the wall.
Okay, let's move up the anatomical ladder. Section 3 in our outline. Anatomy and physiology. Who is the boss? Where is the central control center?
The hypothalamus. Stolting points out that while the brainstem handles a lot of the moment-to-moment reflexes like blood pressure, the hypothalamus is the supreme regulator of the entire autonomic landscape.
Can you be more specific? If I put an electrode in the hypothalamus during an experiment, where do I stimulate to get a sympathetic response?
The posterior and lateral nuclei are primarily sympathetic.
And parasympathetic.
The anterior and medial nuclei.
Correct. Way to remember that.
Rip.
Well, maybe just remember that posterior sounds like posturing for a fight. Sympathetic, whatever works. Let's talk about the neurons themselves. We classify nerve fibers by size and speed, A, B, C. What are we dealing with here?
This is a classic MCQ. Preganglionic fibers for both systems are myelinated B fibers. They are slower than our skeletal motor nerves, the AL fibers, but faster than the smallest pain fibers. And the postganglionic fibers are unmyelinated C fibers.
Which explains why autonomic reflexes have a slightly longer latency than somatic reflexes. It just takes a little longer for the signal to get there.
Right.
Now, the neurotransmitters. This is the exam core. You absolutely cannot pass without knowing these rules cold. Give me rule number 1.
Rule number 1. All preganglionic fibers, doesn't matter if it's sympathetic or parasympathetic release, acetylcholine, or AH.
And the receptor they act on.
Nicotinic receptors, specifically the N sub N nicotinic neuronal subtype.
And why is that distinction N sub N versus N sub M so vital for an anesthetist?
Because it means when I give rocuronium or etracurium to paralyze muscles for intubation, I am blocking the N sub M subtype at the neuromuscular junction. I am not blocking the N sub N at the ganglia, so I don't cause massive autonomic failure every time I intubate someone.
Good differentiation. Rule number 2.
Postganglionic parasympathetic fibers release acetylcholine, which acts on muscarinic receptors at the target organ.
And rule number 3, the main sympathetic rule.
Postganglionic sympathetic fibers usually release norepinephrine, which acts on either alpha or beta adrenergic receptors.
You said usually.
I did. This is the Viva trap.
It is the classic trap. So lay it out for me. Where is the major anatomical exception? Where does a sympathetic fiber, anatomically indistinguishable from the others, release acetylcholine?
The sweat glands.
Right.
They're sympathetically innervated, part of the stress response. But the postganglionic neurotransmitter is acetylcholine acting on muscarinic receptors. Also the piloerector muscles and a few blood vessels and skeletal muscle. But sweat glands are the big one to remember.
Why is that clinically relevant to us every single day?
Well, it explains why we sweat when we're nervous. That's the sympathetic drive. But it also explains why giving an anticholinergic like atropine or glycopyrrolate can cause anhidrosis, a lack of sweating.
And the danger there.
If you give a high dose of atropine to a child in a hot operating room, getting a sweat to cool down, and they can develop iatrogenic hyperthermia, it's because we are blocking that very specific sympathetic cholinergic transmission.
Excellent. Let's move to section 4, functions. This is very high yield. Let's start with the cardiovascular system. This is what keeps the patient alive on the table. Break down the sympathetic effect on the heart using the proper terminology.
Okay, sympathetic stimulation acts via beta-1 receptors. It increases heart rate, that's positive chronotropy. It increases contractility, positive inotropy. And it also increases the speed of relaxation, which is positive lusitropy.
Lusitropy, good word. And the vasculature.
Vasoconstriction via alpha-1 receptors. This increases systemic vascular resistance, or SVR, and maintains blood pressure.
Now, I want to discuss a concept that Guyton loves, and it is vital for understanding why spinal anesthesia causes such profound hypotension. The concept of sympathetic tone. What is it?
Right. This is the idea that the sympathetic system isn't just an on-off switch. It's always simmering in the background. Our blood vessels are normally kept in a state of partial constriction, about 50% of their maximum diameter, by a constant low-level sympathetic firing.
And why is that such an efficient design?
Because it allows for bidirectional control using only one system. The body doesn't need a separate parasympathetic vasodilator nerve for every blood vessel in the body.
So how does it vasodilate?
To dilate a vessel, the brain just turns down the sympathetic tone. It just releases the brakes.
Exactly. And when you perform a subarachnoid block, a spinal, you are chemically cutting those wires. You knock out that baseline tone completely.
The brakes come off.
The brakes come off entirely, the vessels dilate to their maximum, venous return plummets, and your patient's blood pressure hits the floor. It is not an active dilation, it is the loss of that critical baseline tone.
That makes the physiology so much more tangible. It's not just a side effect, it's the direct, predictable mechanism of the block.
Let's briefly touch on the respiratory system.
Sympathetic stimulation causes bronchodilation via beta-2 receptors.
Good. Parasympathetic.
Parasympathetic stimulation causes bronchoconstriction and increases secretions.
Which is precisely why we use glycopyrrolate. It's not just to bring the heart rate up, it's to dry up those secretions and prevent bronchospasm during airway manipulation.
Right.
Now, looking at your notes from Kaushik Jothanath, there was an interesting anecdote about bodybuilders that illustrates sympathetic drive.
Ah, yes, the ECA stack.
Tell me about it. It's a great way to remember the pharmacology of the stress response.
So bodybuilders used to, and some probably still do, use a stack of ephedrine, caffeine, and aspirin to cut fat before a competition.
And what's the mechanism? How does that work?
It's basically an attempt to chemically engineer a permanent fight-or-flight state. Ephedrine forces the release of norepinephrine from nerve terminals. Caffeine inhibits the enzyme phosphodiesterase, which normally breaks down CAMP, so it keeps the second messenger active for longer.
It creates a sympathetic storm in a pill.
Exactly. High metabolism, high energy, fat burning.
And high risk.
And a very high risk of arrhythmia, stroke, and hypertension.
Mm-hmm.
But it perfectly illustrates how the sympathetic system mobilizes energy stores, lipolysis and glycogenolysis, to prepare the body for intense action.
Correct. Now let's pivot to section 5. Autonomic dysfunction. This is where the rubber meets the road for the anesthetist. You have a diabetic patient on your list for a major surgery. Why are you immediately more worried?
Diabetic autonomic neuropathy, or DAN. It's a common microvascular complication that damages the autonomic nerves over time.
I call it the silent killer. Why?
Because of silent myocardial ischemia. The afferent sensory fibers that normally carry the pain of angina are damaged along with the autonomic ones. So a patient with DAN can be having a massive heart attack intraoperatively or even preoperatively and feel absolutely no chest pain.
So you are just looking at the monitor, the ST segments are dropping, the BP is swinging, but the patient isn't complaining of anything. You have to have a very high index of suspicion. What else does DAN do to the stomach?
Gastroparesis. The vagal control of the stomach is gone. It doesn't empty properly.
Right.
So even if they have fasted for 10 or 12 hours, you have to treat them as a full stomach risk.
Meaning?
Meaning you have to do a rapid sequence induction, or RSI, to secure the airway quickly and prevent aspiration.
Good. And what about their hemodynamic instability under anesthesia?
Their compensatory reflexes are completely shot. Normally, if I give a dose of propofol and the pressure drops, the baroreceptor reflex kicks in and the heart rate speeds up to compensate.
And in a DAN patient?
In a DAN patient, the heart rate is fixed. It's like a metronome. It doesn't respond. They rely entirely on circulating volume. So if I vasodilate them with an anesthetic, the pressure just crashes and stays there.
So how do you test for this at the bedside? You have 5 minutes in the pre-op holding area. What can you do?
Heart rate variability. I'd ask them to take slow, deep breaths, about 6 breaths per minute. I'd watch the ECG monitor. Normally, the heart rate should speed up on inspiration and slow down on expiration. That's sinus arrhythmia.
And if it doesn't?
If the RR interval on the ECG is fixed and doesn't change with breathing, that's a very strong sign of severe autonomic neuropathy. The Valsalva maneuver ratio is another classic test.
Good. That is a solid pass on the ANS section. But the Viva isn't over. Let's move to Part B, pupils.
The window to the brainstem.
Indeed. Section 6, Anatomy and Physiology of Pupillary Control. Examiners love to ask you to draw this because it tests your knowledge of cranial nerves and the sympathetic chain simultaneously. Let's trace the wires. Walk me through the parasympathetic pathway, the constriction pathway.
Okay, right. I'm visualizing it now. It starts in the midbrain.
Where in the midbrain? Be specific.
At the Edinger-Westphal nucleus specifically.
Good. The fibers leave with which nerve?
They exit via the oculomotor nerve, so cranial nerve the third. They travel to the orbit and synapse in the ciliary ganglion.
And from the ganglia?
From there, the short ciliary nerves carry the signal to the sphincter pupilla muscle of the iris.
And the result is?
Constriction. Meiosis.
That's the easy one. Now, the sympathetic pathway. Dilation. This is a journey. It's a 3-neuron chain, and it explains a lot of pathology. Start at the top. Where does it begin?
The first-order neurons start way up in the hypothalamus. They descend all the way down the brainstem to the spinal cord.
To where in the spinal cord?
Specifically to the ciliospinal center of Budge, at levels C8 to T2.
Correct.
So,
Budge is center. Then, second-order neuron.
The second order, the preganglionic fibers, exit the spinal cord. They travel over the apex of the lung, which is a really important clinical landmark, and go up to the superior cervical ganglion in the neck.
And the third order. This is the tricky part.
This is the tricky part. The postganglionic fibers form a plexus that wraps around the internal carotid artery. They basically hitch a ride on the artery wall to get into the skull. They then join the ophthalmic division of the trigeminal nerve, travel via the long ciliary nerves, and finally hit the dilator pupillae muscle,
resulting in mydriasis dilation. Now, why did I make you trace that whole convoluted path? Because of the clinical correlations. Let's talk about the light reflex. I shine a light in your left eye. What happens?
The left pupil constricts. That's the direct reflex.
Yeah.
But the right pupil also constricts. That's the consensual reflex.
That's why. What is the anatomical basis for that crossover?
The afferent signal travels in via the optic nerve, so CN22, to the protectal nucleus in the midbrain.
Okay.
From the protectal nucleus, neurons project bilaterally to both the left and the right Edinger-Westphal nuclei. It sends the constrict order to both sides simultaneously.
Exactly. So if you shine a light in a patient's blind left eye and the right pupil constricts, what have you just proven?
I've proven that the left optic nerve is damaged, the afferent limb is out. But the consensual response tells me that the midbrain connection and the efferent motor pathways to both eyes are intact.
Perfect. Section 7, clinical examination. We look for anisocoria, unequal pupil size. If you see a patient with one pupil 1 millimeter larger than the other, do you panic?
Not necessarily. About 20% of the population has physiologic anisocoria. The key is to check if the difference is the same in both bright and dim light to rule out pathology.
Let's talk about the pathologies that scare us. Section 8, diagnostic importance. Give me the differential for bilateral pinpoint pupils.
The classic one is an opioid overdose.
Yeah.
Bilateral intense constriction.
What else? Think structural brain lesion.
A pontine hemorrhage. A bleed in the pons.
And why does a bleed in the pons cause pinpoint pupils? Connect it back to the anatomy.
Because that long sympathetic pathway we traced, the first-order neuron, descends right through the pons. A hemorrhage there wipes out the sympathetic drive coming from the hypothalamus, leaving the parasympathetic tone from the Edinger-Westphal nucleus completely unopposed, so the pupils just clamp down.
Good. Now the opposite. Bilaterally dilated and fixed pupils.
That is a grave sign. That means severe brainstem hypoxia, brain death, or pharmacologically, a massive overdose of an anticholinergic like atropine or scopolamine.
Let's talk about Horner's syndrome. This relates back to that long sympathetic pathway we traced. What is the classic triad?
Ptosis, which is a droopy eyelid, meiosis, a constricted pupil, and anadrosis, a lack of sweating on that side of the face.
And the mechanism.
It's any interruption of that three-neuron sympathetic chain. It could be a Pancoast tumor at the apex of the lung, compressing the stellate ganglion. That's why the lung apex path matters. Or a carotid artery dissection affecting the third-order neurons as they travel up the artery. As an anesthetist, when do we cause this?
It's a very common and expected side effect of a stellate ganglion block or an interscalene block for shoulder surgery. If the local anesthetic spills over anteriorly onto the sympathetic chain, you will get a temporary Horner's.
Correct. And you must warn the patient about this beforehand. If they wake up, look in a mirror, and see one droopy eyelid and a tiny pupil, they'll think they're having a stroke.
Absolutely.
One more critical pupil sign, Hutchinson's pupil.
This is the neurosurgeon's nightmare. It's a dilated pupil on the same side as an expanding intracranial mass. Explain the mechanics. Why does that happen?
It's caused by uncal herniation. As the pressure builds, the temporal lobe pushes down and compresses the oculomotor nerve, CN the third, against the tentorium.
And why does that cause dilation?
Because the parasympathetic fibers that constrict the pupil run on the outside of the nerve sheath, so they get crushed first. You lose the ability to constrict, and the sympathetic tone takes over, blowing the pupil wide open.
Excellent. That is a surgical emergency requiring immediate decompression. Now, briefly, Section 10. Anesthetic relevance. We know opioids cause meiosis. What do our volatile anesthetics do?
Volatiles like sevoflurane generally cause a mild dilation. And at very deep levels of anesthesia, stage 3, plane 2 or 3, you'll lose the light reflex entirely.
Miller cites a very specific study regarding this dilation involving a drug called dapiprazole. Do you recall it?
Yes, I have that in my notes.
Yeah.
Dapiprazole is an alpha-adrenergic blocker. It basically creates a chemical Horner's in the eye by blocking the dilator muscle. The study showed that even when you block the sympathetic muscles in the eye using dapiprazole, the pupil still dilates under anesthesia.
So what does that tell us about the mechanism? It's not just sympathetic stimulation.
It implies that the dilation is centrally mediated. It suggests that the anesthesia is directly inhibiting the Edinger-Westphal nucleus. It's turning off the constriction center in the brainstem itself.
That is the kind of nuance that gets you the gold medal. It shows you understand the mechanism, not just the road observation.
Oh, okay. Moving on. We've done the wiring with the ANS. We've done the window with the pupils. Now let's talk about the aftermath. Part C, postoperative cognitive dysfunction, or POCD.
This is a huge topic in modern anesthesia, especially with our aging population. Section 11. First, define it clearly for me and distinguish it from delirium. This is the most critical distinction you can make.
Okay. POCD is a subtle but persistent deterioration in cognition. We're talking memory, concentration, executive function that happens after surgery and anesthesia. It can persist for weeks or even months.
And delirium, how is that different?
Delirium is acute. It happens in the recovery room or on the ward in the first few days. It fluctuates wildly. The patient is confused, agitated, or sometimes hypoactive and unresponsive. Their level of consciousness is altered.
Whereas in POCD, yeah,
consciousness is normal. They are awake, they're alert, they just aren't as sharp as they were before the surgery.
Give me an example of how a family member might describe POCD to you.
They might say, Dad is back to normal physically, but he can't do the Sunday crossword anymore. Or, she keeps forgetting her grandkids' names. It's a cognitive fog, not a storm.
Exactly. Delirium is the storm, POCD is the fog. How do we diagnose POCD? Can you do it with a quick bedside test?
Not really. The MMSE, the Mini Mental State Exam, is often too crude to pick it up. You really need a battery of sensitive neuropsychological tests, and ideally you need a baseline pre-op score to compare against.
So it's often a retrospective diagnosis.
Right, usually diagnosed 1 to 3 months after surgery when the family really notices something is wrong.
Let's look at the pathophysiology in Section 12. Why does this happen? Is it just that anesthesia kills brain cells?
That was the old fear, but the leading theory now is neuroinflammation.
Unpack that for me.
Surgery causes tissue damage. That releases a storm of inflammatory cytokines like IL-1, IL-6, TNF-alpha into the blood.
But the brain is protected by the blood-brain barrier, isn't it?
Normally, yes. But in high-stress states like major surgery, the blood-brain barrier can become permeable or leaky. The cytokines cross over and activate the microglia, the brain's resident immune cells.
And then what?
This sets off a local inflammatory fire in the brain, which can damage neuronal connections and impair synaptic plasticity, specifically in vulnerable areas like the hippocampus, which is crucial for memory.
Correct. So it is not just the drugs, it is the inflammatory response to the surgery itself. What else contributes?
Cerebral hypoperfusion or hypoxia. If you have episodes of intraoperative hypotension or microemboli, especially common in cardiac surgery, you can get microischemia in the brain. There's also the cholinergic hypothesis, that we deplete the brain's acetylcholine reserves.
Which is why we are so careful with anticholinergic drugs in the elderly. Speaking of which, Section 13, risk factors. If I want to predict who is most likely to get POCD, what is the #1 variable?
Age. Advanced age is by far the strongest predictor.
What else?
A lower education level. This speaks to the concept of cognitive reserve.
Explain that.
If you have more dense neural networks to begin with, for more education, more lifelong mental activity, you can afford to lose a few connections without showing obvious symptoms. Someone with less reserve is more vulnerable.
Makes sense.
Also, the type of surgery matters. Cardiac surgery with cardiopulmonary bypass is the highest risk, and major orthopedic surgery like hip fractures is also very high risk.
Now, the million-dollar question in Section 15, the examiner looks at you over his glasses and asks, Doctor, my mother is 82 and having a hip replacement. She is terrified of losing her memory. Should I insist on a spinal anesthesia instead of general anesthesia to prevent POCD? What is your answer?
It's a counterintuitive answer, and it's a difficult conversation to have, but the answer based on the current evidence is, it probably doesn't make a significant long-term difference.
That shocks people. Why wouldn't staying awake and avoiding GA drugs help?
Because of the stress response we just talked about. The surgery itself causes the inflammation. Whether you are asleep under a general anesthetic or numb from the waist down with the spinal, the knife still cuts, the bone is still reamed, the cytokines are still released, and the microglia.
The inciting event is the surgery. Now, regional anesthesia might reduce the incidence of early confusion delirium in the first few days, but for long-term cognitive decline, that inflammatory cascade seems to happen regardless of the anesthetic technique. As is the correct exam answer, it demonstrates, the literature. However, we still take precautions. Section 16, prevention. What is the bundle approach?
It's basically just high-quality, geriatric-focused anesthesia and perioperative care.
Give me some components.
Okay, so pre-op optimization, fix their hydration, their nutrition, their anemia. Intra-op maintain strict normotension, normocarbia, and normothermia. Avoid hypoxia at all costs. Some people advocate using depth of anesthesia monitoring like BIS to avoid excessively deep anesthesia, though the data is a bit mixed.
And which drugs should you absolutely try to avoid in an elderly patient?
Multimodal analgesia is key to spare opioids, and specifically, you want to avoid centrally acting anticholinergics like atropine or scopolamine, and of course, avoid benzodiazepines.
Why avoid benzos like the plague?
They were just notorious for causing delirium and prolonged cognitive impairment in the elderly. A shot of midazolam in an 80-year-old as a pre-med is a recipe for a very confused and prolonged wake-up.
Agreed. So, bringing it all together, we've covered the autonomic wiring, the pupillary window, and the cognitive fallout. Before we wrap up, I want to review Section 17, common exam questions and viva traps. We mentioned the sweat gland trap. What is another one related to the pupil?
Confusing the effects of ganglion blockers versus atropine on the pupil.
Explain the difference. What would I see?
Atropine blocks the muscarinic receptor at the sphincter muscle directly. The sympathetic dilator is left completely unopposed, so the pupil blows wide open. You get maximal mydriasis.
And a ganglion blocker.
A ganglion blocker, like hexamethonium, knocks out both sympathetic and parasympathetic ganglia, so you lose both constriction and dilation tone. The pupil goes to a mid position and is fixed. It doesn't dilate fully because the sympathetic drive is gone too.
Excellent distinction. Another trap is autonomic dysreflexia in a patient with a spinal cord injury. If a patient with a high spinal injury, say, above T6, suddenly becomes severely hypertensive on the table, what is the first non-pharmacological thing you check?
The bladder, or the urinary catheter. A distended bladder is a massive sensory stimulus below the level of the injury.
And what does that do?
It triggers a massive, unchecked sympathetic outflow. But because of the spinal injury, the brain can't send inhibitory signals down to calm it. So you get runaway hypertension, bradycardia, and sweating.
Correct. And in the PCCU, if any elderly patient is agitated or delirious?
Check the bladder again. A full bladder is probably the most common and most easily reversible cause of emergence agitation.
Good. Now, section 18, diagrams. You cannot pass this exam without being able to draw. What are the 3 diagrams you need to practice tonight?
1, the baroreceptor reflex arc.
Mm-hmm.
2, the pupillary light reflex.
Yeah.
And you have to specifically show the crossing over at the protectal nucleus to explain the consensual response.
Yeah.
And 3, a simple flowchart for managing intraoperative hypotension in a patient with diabetic autonomic neuropathy.
If you can draw those 3 clearly, you will score marks even if your verbal answer is a bit shaky. The examiners are tired by the end of the day. They like clear pictures.
Okay, let's summarize. Section 19, give me the high-yield take-home recap.
Okay, bullet points. 1, ANS is about homeostasis. Know the difference between mass discharge for sympathetic and discrete control for parasympathetic. Don't forget the enteric system exists.
Got it.
2, neurotransmitters. Preganglionic is always acetylcholine on a nicotinic receptor. Postganglionic is acesiose on muscarinic for parasympathetic and norepinephrine on adrenergic for sympathetic, except for the sweat glands.
Right, the trap.
3, pupils are the window to the brainstem. The consensual reflex proves the midbrain connection is intact. Horner's is a sympathetic knockout. Hutchinson's is CN, the third compression. Know those cold.
Okay.
And 4, POCD. It's inflammatory, not just a drug effect. Age is the #1 risk factor, and regional anesthesia does not guarantee protection against the long-term cognitive fog.
That is a lot to take in, but breaking it down by mechanism really, really helps.
The key in the Viva is confidence, and confidence comes from understanding the fundamentals. Treat the physiology as the foundation. If you understand the wiring, the anatomy, the pathology will make perfect sense. You don't have to memorize a list of symptoms for Horner's if you can just trace the nerve in your head and see what it does.
Treat the physiology as the foundation. I like that. I'll write that too.
Good. Now go draw those diagrams. Right now, while it is fresh.
Will do. Thank you, Professor. This was incredibly helpful.
Good luck with the exam. You have got this.
And to our listener, our fellow candidate, draw the diagrams. Take a deep breath. You know more than you think you do. We'll see you in the next deep dive.